Hi there, my name is Suzanne Savage, and I'm a DNP student, and this will be my oral presentation describing my DNP project in its entire completion. The project is called Implementation of a Clinical Practice Guideline, Deprescribing Proton Pump Inhibitors in Primary Care. Before I begin, I would like to acknowledge my appreciation and my thanks for all the assistance and help that my DNP chair, who happened to also be my second reader, Dr. Marilyn Riley, was there to help me. So I appreciate that, along with all her feedback. I'd like to share a little background information about myself. I have been a nurse for 32 years. I've been an APRN for 15, and I currently work in primary care in an internal medicine office in an urban setting in the Midwest. And what finally, through weeks of research and self-reflection, finally pinpointing what I wanted to do my project about was regarding proton pump inhibitors. And what I do see on a daily basis is the long-term utilization of these class of medications, whether they are for benefit or possibly detrimental adverse effects. Therefore, I decided to choose this as my project. So the purpose of my project, scholarly project, was to implement an evidence-based clinical practice guideline to support deprescribing of proton pump inhibitors in primary care setting. And this was only in adult patients because that is the population that I serve. The aims of my project were to increase provider knowledge of evidence-based indications and recommend the correct duration of PPI therapy, support routine reassessment of long-term PPI use in adult primary care patients, promote appropriate deprescribing PPIs when clinical indications are no longer indicated, and then reduce inappropriate long-term PPI use and associated risks throughout guidance. Gastroesophageal reflux disease, or otherwise known as GERD, is one of the most common gastrointestinal diseases or conditions worldwide, with more than 75% prevalence increasing in the past 3 decades. Proton pump inhibitors play an essential role in the treatment of these diseases and are prescribed at exceptionally high rates. Proton pump inhibitors are one of the most commonly prescribed medications for this disease and for other upper gastrointestinal disorders. In 2020 alone, omeprazole was the second most dispensed medication in England. However, despite national and international data demonstrate that these lack appropriate ongoing indications, this widespread overuse leads to unnecessary healthcare costs, let alone polypharmacy that I believe that we are all trying to address in primary care. And this also points to avoidable patient risk, highlighting an important opportunity for practice change. Although clinical practice guidelines recommend limited treatment duration, PPIs are frequently continued indefinitely without any kind of reassessment being done. In primary care settings where PPI prescriptions originate, providers often lack structured tools to readdress this issue and making guided decisions for deprescribing. This practice gap places patients at risk for long-term adverse effects and underscores the need for an evidence-based clinical practice guideline and focused on deprescribing. Evidence supports short-term or time-limited PPI therapy for most indications, such as GERD. Routine reassessment and deprescribing do not consistently occur in primary care, and there is a lack of standardized deprescribing guidance, and it contributes to inappropriate long-term use, increased risk of adverse effects, and unnecessary healthcare costs, as previously mentioned. And this is where primary care does play a pivotal role in addressing unnecessary medications, and PPIs are one of those. So what, you might ask, disorders in the GI tract do PPI medications are deemed appropriate for utilization? Those would be gastroesophageal reflux disease, gastroduodenal ulcers, Barrett's esophagus, and Zollinger-Ellison syndromes. Also, those on long-term NSAID therapy, such as naproxen or ibuprofen, meloxicam, those also may need to have gastroprotective mechanisms by utilizing PPIs. As far as long-term utilization of PPIs, those are the patients that need gastroprotective reasons for long-term NSAID use, those with Zollinger-Ellison and those with Barrett's esophagus. Overarching indications would be short-term utilization or time-limited for most, reducing risks and by improving outcomes. Medications are also used for functional dyspepsia and prevention of medication-induced gastropathy, like I'd mentioned before, with NSAID use. Okay, now we turn to literature review. The literature consistently demonstrates a mismatch between evidence-based recommendations and real-world prescribing practices. While PPIs are effective for specific gastrointestinal conditions, most patients require only short-term use. Prevalence and overuse. GERD prevalence has increased globally, contributing to the rising PPI prescribing rates. Up to 89% of PPIs are prescribed without an appropriate indication, often continued long-term. Clinical guidelines and appropriate use. I reviewed national guidelines, and overarching recommendations were for short-term PPI therapy for most indications. Long-term use, again, is reserved for a limited number of conditions, Barrett's esophagus and Zollinger-Ellison syndrome. The clinical practice guidelines that were reviewed were by the American College of Gastroenterologists and the American Gastroenterologist Association. They clearly outline inappropriate or appropriate use and emphasize deprescribing when indications are no longer indicated and no longer present. Randomized and prospective studies show that both tapering and abrupt withdrawal can be successful, with most patients remaining off therapy. However, the absence of standardized deprescribing tools in primary care contributes to ongoing utilization and inappropriate use. This highlights the need for an evidence-based clinical practice guideline. While the literature generally supports deprescribing PPIs, when indications are no longer present, several key gaps and controversies do exist. This should be acknowledged. First, much of the evidence related to inappropriate PPI use and deprescribing outcomes is heterogeneous and largely observational. Studies differ in how they define inappropriate use. The population studied and outcome measurements, this variability introduces confounding and limits the ability to draw causal conclusions. Second, the evidence surrounding long-term safety risks of PPIs remains controversial. Although prolonged PPI use has been associated with conditions such as fractures, chronic kidney disease, and infections, many experts caution that these associations may reflect indication bias or residual confounding, rather than a direct causal relationship. As a result, uncertainty about true long-term harm can make both providers and patients hesitant to deprescribe. Another important controversy involves deprescribing strategies. Research shows that both gradual tapering and abrupt cessation can be effective, but outcomes vary depending on patient characteristics, education, and follow-up. While rebound acid hypersecretion is common, it is typically very self-limited, and however, fear of symptom recurrence remains a significant barrier to this deprescribing. And finally, implementation studies demonstrate that deprescribing efforts often result in mixed or short-lived improvements, particularly in the absence of standardized tools or system-level support. This highlights again the challenge of translating evidence into sustained practice change. Together, these gaps reinforce the need for a clear and structured evidence-based clinical practice guideline. And this would be designed specifically for primary care, would be my recommendation. And the plan for this project that was performed and completed. Such guidance can help address uncertainty, support clinician decision-making, and promote consistent, sustainable PPI prescribing. Okay. Given the variability of evidence, the ongoing safety debates, and challenges with sustaining a deprescribing efforts, it became clear that simply providing evidence was not enough, and a structured change framework was needed to support adoption and sustainability. For this reason, Lewin's change theory was selected as the conceptual framework guiding for this project. To guide both the development and implementation of this project, Lewin's change theory was selected as this conceptual framework again. This theory was particularly well suited because deprescribing represents a behavioral and practice change, not just a knowledge deficit. Lewin's change theory consists of 3 phases: unfreezing, changing, and refreezing, all of which directly informed the design of this project. During the unfreezing phase, the focus was on recognizing the problem of inappropriate long-term PPI use. This involved increasing provider awareness of evidence-based indications, recommended treatment duration, and potential risks associated with prolonged therapy. Introducing the evidence and highlighting the practice gap helped create readiness for change. The changing phase centered on active intervention. In this phase, the evidence-based PPI deprescribing clinical practice guideline was implemented, and providers were educated on appropriate indications, duration of therapy, and deprescribing strategies, including tapering versus abrupt discontinuation. This phase supported providers in translating evidence into clinical practice. Finally, the refreezing phase focused on sustainability. The goal was to embed deprescribing practices into routine primary care workflows through consistent guidance and reinforcement. Emphasis was placed on an ongoing reassessment of chronic PPI therapy to support long-term change in prescribing behavior. Overall, Lewin's change theory not only provided a conceptual foundation, but also guided the sequencing of interventions, informed the development of provider education materials, and supported the sustainability of practice change. Using this framework helped ensure that the guideline was not only evidence-based, but also practical, implementable, and aligned with real-world primary care practice. Now regarding the methods and design of my project, the overview. The guideline was developed using a systematic review of the literature, addressing PPI overuse and deprescribing practices. To ensure rigor and clinical relevance, both quantitative and qualitative evaluation methods were used. Upon completion, the guideline was appraised by 5 actively practicing clinicians using the agreed instrument, a validated framework for evaluating the methodological quality and transparency of clinical practice guidelines. Okay, we conducted a systemic literature review addressing PPI overuse and looking into the appropriate indications and duration and deprescribing strategy. Recommendations based on best available evidence and expert consensus. Evaluation approach. I employed quantitative and qualitative methods to assess guideline quality and relevance. Appraisal process. Clinical practice guideline was evaluated by a panel of 5 healthcare professionals. 4 were internal medicine physicians and 1 family nurse practitioner, APRN. And they were all actively practicing clinicians. The evaluation tool was the Agreed To instrument, 23 items across 6 domains. It employs a 7-point Likert scale and includes overall quality rating and the recommendation for use. This next slide is showing us the Agreed To instrument, domains, distribution, and how they are weighted. So the first part, and it is 6 distinct quality domains. Editorial independence is 8.7, applicability is 17.4, clarity of presentation 13, rigor of development 34.8%, stakeholder involvement 13, scope and purpose another 13%. And this again would be distribution based on number of items per domain. There are 23 total items. Next section is describing sample, which the project did not involve any human participants. Instead, the sample consisted of clinical appraisers who evaluated the quality of the developed clinical practice guideline using the Agreed To instrument. After the guideline was developed, the student investigator contacted the potential reviewers and invited them to participate by providing structured feedback. Participation was entirely voluntary. Recruitment and communication continued until at least 4 reviewers completed the Agreed To instrument. I ultimately ended up with 5 reviewers. Ultimately, they completed the appraisals, one of which was an APRN. The project was conducted in an urban primary care setting in the Midwest, as mentioned before. This ensures that reviewer feedback reflected real-world applicability. On the inclusion criteria, they had to be in adult primary care, acid-related gastrointestinal disorders, and then proton pump inhibitors had to be prescribed by these clinicians. Next up, we'll discuss data analysis. Data collection and analysis followed a structured, evidence-based process using the Agreed To instrument. Appraisers independently reviewed the clinical practice guidelines and completed the instrument, generating multiple types of data. Ordinal quantitative data was obtained from domain items, rating using a 7-point Likert scale. Nominal data was collected through the final Agreed To item, which, when asked reviewers to indicate whether they would recommend the guideline for use. In addition, qualitative data were gathered through open-ended written comments, allowing reviewers to provide contextual feedback and suggestions for refinement. Scaled domain scores were calculated using Agreed To scoring instructions. For each domain, the minimal possible score was calculated by multiplying a score of 1 by the number of items and the number of appraisers, while the maximum possible score was calculated using a score of 7. The scale domain score was then calculated with a threshold of 85% or higher, which was established to indicate sufficient methodological rigor and clarity. Scores below this benchmark were considered areas for improvement. Quantitative results were analyzed alongside qualitative feedback to identify both strengths and weaknesses of this guideline. Notably, 5 of the 6 Agreed To domains exceeded the established quality threshold, while 1 domain scored substantially lower. Despite this outlier, all appraisers recommended the guideline for use. This mixed methods approach supported a comprehensive multidimensional evaluation of the guideline and informed targeted revisions while confirming the guideline's overall readiness and for future implementation in primary care. Next up, result. Here's overall findings. 5 of 6 Agreed To domains exceeded the established quality benchmark greater than 85% or equal to. 1 domain scored substantially lower at 11%, highlighting a specific area requiring improvement. Importantly, despite this lower domain score, all appraisers did recommend the guideline for its use, either without modification or suggested refinements, which none did. These findings support both the overall strength of the guideline and the value of the agreed to process in identifying targeted opportunities for improvement for future implementation in primary care. The domain of editorial independence was the domain that scored the lowest due to possibly lack of external funding and formal conflict of interest declarations, typical of large-scale guideline development rather than clinical or methodological qualities. This figure provides a visual summary of the agreed to appraisal results. As shown, 5 of the 6 domains met or exceeded the established quality benchmark of 85%, indicating strong methodological rigor, clarity, and applicability of the clinical practice guideline. I do want to address and mention limitations in my project. Several limitations should be considered when interpreting the results of this project. First, the clinical practice guideline was developed and evaluated within a single urban primary care setting. While this context supports relevance to similar practices, it may limit generalizability to other clinical environments, such as rural health clinics, specialty practices, or larger healthcare systems. Future research using multi-site designs could improve valuable insight into the guideline's scalability, adaptability, and effectiveness across diverse practice settings. Additionally, the number of appraisers was quite small, although it did meet the agreed to tool minimum recommendations. While the sample size was appropriate for guideline appraisal, a larger and more diverse group of reviewers may yield additional perspectives. Another limitation is that my project focused on guideline development and quality result. The impact of the guideline on clinical practice and patient outcomes could not be assessed within the scope of the project. Finally, consistent with student-developed and locally focused guidelines, external stakeholder engagement and formal dissemination strategies were limited. These elements represent important opportunities for future refinement of the guideline. Despite these limitations, the project provides a strong foundation framework for evidence-based PPID prescribing and supports future implementation and evaluation efforts in primary care. In our discussion slide, the purpose of this scholarly project was to implement an evidence-based clinical practice guideline to support the deprescribing of proton pump inhibitors in adult primary care patients. The findings from the agreed to appraisal demonstrate that this aim was met. 5 of the 6 agreed to domains exceeded the established quality benchmark, indicating strong methodological rigor, clarity of presentation, and applicability of clinical practice. These results suggest that the developed guideline effectively addresses the identified practice gap by providing structured evidence-based guidance to support appropriate reassessment and deprescribing of long-term PPI therapy. Reviewers consistently noted the guideline's clarity and relevance, which aligns with the project's goal of improving provider knowledge regarding appropriate indications and treatment duration. Although the editorial independence domain scored lower, this finding reflects the academic scope of the project rather than deficiencies in clinical content or methodological quality. Importantly, all appraisers recommended the guideline for use, supporting its overall validity and readiness for future recommendations. Let's see. Implications for practice. It supports routine reassessment of long-term PPI therapy in primary care, provides a clear evidence-based guidance for appropriate deprescribing of PPIs, enhances provider knowledge, promotes medication safety, and serves as a practical implementable tool. In a quick conclusion, inappropriate long-term PPI use represents a significant and addressable practice goal or gap in primary care. This project successfully developed and evaluated an evidence-based PPI deprescribing clinical practice guideline, and the agreed to results demonstrated high guideline quality and implementation readiness. The guideline provides a practical tool to support safer prescribing and medication optimization, and finding support future implementation and evaluation in diverse primary care settings. A complete reference list is provided here with key sources drawn from national guidelines, Deprescribing literature, and the Agreed To framework that guided the development and evaluation of this project. Thank you.